for inviting me, and it's my pleasure to be here. I guess this is the second time I've talked in this room, but the good news about melanoma is we're making advances so fast that I have lots of new stuff to talk about that hadn't happened last year. So melanoma is, as was mentioned, not the most common cancer, but it's one of the cancers that is increasing the most rapidly, both in men and women. The incidence has tripled just in the last 20 years and has gone up even more fold in the last, 60, 80 years. Used to be people thought that light-colored skin was a mark of aristocracy and people who didn't have to work in the fields. But somewhere in the last century, everybody got the idea that no, light-colored skin is pale and weak, and you need a nice, robust tan. And so instead, or maybe along with the tan, there's a nice, robust increase in melanoma. And it's already been mentioned that UVB and UVA both contribute, and tanning salons actually found the perfect formula to decrease the amount of burning from the UV rays they used without decreasing the amount of melanoma. So tanning salons are particularly bad. So this just shows you melanoma is kind of in the middle of really common to really rare cancers. That adds up to about 7,000 a year in Canada. So it's a real problem. Sonia mentioned the ABCs of melanoma. We're now up to ABCDE. As you can see, the lesions on top, does this point? Maybe not. The lesions on top are benign, they're symmetrical, they have even borders, they just have one color, they're not too big, and most importantly, they don't get bigger or change with time, whereas below you see examples of melanomas which meet all these high-risk criteria. There are different types which have different presentations. Some more common in young patients, some more common in older patients, some more common with chronic sun exposure. Nodular can often be missed because it's not always black and it grows fast and therefore needs to be caught as soon as possible. And Sonia mentioned acromelanoma. So how do you tell how bad a melanoma is? We have a staging system that can be made complicated, but is really pretty simple. The T stage for thickness of the tumor is probably the first important thing. If it's really small, and that's over in the left, what used to be called Clark level 1, it has a very good chance of being cured by simple surgery, and you never need anything else. And the bigger it is, the more chance it will have already probably spread somewhere, which may only become apparent later on. The next important thing is lymph nodes, and I won't bore you with all the different kinds of lymph node spread and number, but the bottom line is if you have no lymph nodes, you have a low risk of recurrence. If you have one or more lymph nodes, you have a significant risk of recurrence, and especially multiple lymph nodes means more likely the disease is going to come back than not. So there's a staging system, and without going into the details, 80% are early stage, although some of these are higher risk to come back than others. 15% are found with positive lymph nodes, and I talked about their risk, and only 5% plus or minus start out as metastatic disease when you first notice them, although unfortunately, as I mentioned, a lot of these other guys ultimately become metastatic. So what else do you need to know about a melanoma? You need to know its BRAF status, whether it's mutated or not, as Sonia pointed out. And if it's in certain areas, acral or mucosal, or for example, uveal in the eye, that predicts a different behavior and is important to know. You don't always need to scan people. Usually we only do scans for people who have an increased risk of recurrence, so big tumors without lymph nodes and any tumor with lymph nodes. Melanoma, unfortunately, often goes to the brain, so we sometimes scan the head. So how do you treat localized disease? As I mentioned before, if you can cure it by cutting it out, that's a good thing. So you do a wide excision, and exactly how wide depends on the depth of the tumor in the first biopsy. As I mentioned before, risk goes up as the size of the tumor, as the depth goes up. And this is what we do for all but the smallest tumors. We look for where dye injected into the tumor would go in the lymph system, and that's most likely where tumor has gone. So all we have to do is cut out the 1 or 2 sentinel lymph nodes, and you don't have to take all the lymph nodes from the possible drainage area. And once you have those lymph nodes, as I said before, if they're negative, then that implies a better prognosis, and if they're positive, that means you probably have more work to do. Important to notice, this helps with prognosis. It doesn't actually change the long-term outcome. So cutting out the lymph nodes, even initially, doesn't change overall survival. And the big studies in surgery in the last couple of years in melanoma have been, what is the role of the completion lymph node dissection? That means if you have a positive node, the theory is there's risk that there are other nodes that are positive, and cutting out cancer is a good thing. So for a long time, surgeons recommended everybody who had a positive node got all their nodes in the region taken out. Turns out 2 big recent trials planned and done by surgeons, and then initially they didn't like the results, but I think they're coming around to the idea. Both trials show that there is no improvement in anything, not melanoma-specific survival, not overall survival, not metastasis-free survival, by doing the completion dissection. There's just problems with wound healing and problems with edema. So in only rather unusual cases, unless there is a palpable tumor still there in the lymph node area, in which case you need to cut it out, we don't do completion dissections. Here's just one curve, melanoma-specific survival observation versus doing the surgery. You can tell those curves are pretty superimposed. So how do we treat advanced disease? This is what the survival curve was for decades, and this is the survival curve in patients who were healthy enough to go on clinical trials in the 70s, 80s, 90s. And the 1-year survival was just a quarter of the patients, and the median average survival was 6 months. So that's changed, and I'll show you a bunch of survival curves that are much better in a minute. You heard about this, BRAF mutations turn on this growth pathway independent of all other signals in the cell. Most BRAF mutations are the specific V600E, but there's some other ones that we try to catch as well, because they also often respond to targeted therapy. This is just one slide from a number of studies that showed that targeted therapy is way better than chemotherapy. On the left, you have what they call the waterfall plot, and those few little cases you can see at the far left are the ones where the tumor just grew on treatment. And all the ones on the right side below the dotted line, which is 0, show shrinkage of the tumor as response to therapy. So the therapy really works in almost everybody, at least for a while, and I'll get back to that. And here is the PFS curve, progression-free survival, that you'll see in lots of papers about lots of therapies for cancer. And you don't have to be a statistician to see that the blue, the vemurafenib line is way above the chemo line. So that's kind of the good news. This is a patient who had a lot of disease. He got vemurafenib and it all went away. That was the good news. Also, it went away fast in 15 weeks. The bad news, 8 weeks later, it was all back and actually didn't go well for the patient. So targeted therapy works fast. It works to a greater or lesser extent, but mostly a pretty good extent in almost everybody, but it doesn't last long enough. There were a bunch of trials. I won't show you all these in detail. I'll just show you that in the top monotherapy studies, a targeted agent is always better than whatever chemo it was compared to, and these numbers kind of speak for themselves, especially the response rate. We did combination studies, and remember I showed you BRAF is here. Right below it is this signaling molecule called MEK. And if you hit BRAF with an inhibitor and you hit MEK with an inhibitor, that's the combination studies. As you can see, again, the combination is always better than the single agent. So lots of studies. Single agent RAF inhibitor therapy came and went. Now everybody uses double. And this is a survival curve from more recently with the double combo that's used mostly in Canada and mostly in the rest of the world now. I won't get into the details why people like this a little bit better than the other combination, but you can see the survival is hugely better than the curve I showed you at the beginning. So it helps. How can you predict who is going to respond best to targeted therapy? This is a bit of a complicated slide. I'll just go over the two things that are circled in yellow. If the patient has a normal, what's called LDH, it's a blood enzyme that is often increased when you have a lot of tumor, and the patient doesn't have disease in too many places, the 3-year survival is 70%. That's huge compared to the past, and actually is as good as any of the immunotherapy studies, maybe better. So if you don't have a lot of disease, you can get a lot of time, hopefully with minimal side effects, although the drugs do sometimes have side effects, with targeted therapy. In contrast, if you have a lot of disease, LDH is high, especially LDH 2 times normal, 2-year survival is 7% as opposed to 70%. And 3-year survival obviously is bad too. What does that mean? It means what we thought maybe 5 years ago, which was targeted therapy works really fast in almost everybody, and immune therapy takes a while to get going and doesn't work as well in everybody. And so therefore, if you had bad disease, you needed targeted therapy first if you were eligible. Turns out that's probably exactly wrong, because the targeted therapy, although it works, really doesn't work for very long. And immune therapy in patients with more disease can still give you long-term remissions, at least in some patients. But data keeps coming in every year, and we change our minds before we might change our minds again. I will just briefly show you what's coming. There's a new combination, the third combination of drugs that are called encorafenib and binimetinib. They're going to have easier trade names soon. They may already, but I don't know them yet. The combination, once again, is better than single agent comparator, which in this case was vemurafenib. What I didn't focus on was the median progression-free survival in all the other combination versus single agent trials I showed you with the Roche and the Novartis compound. The combo was 12 months, 11.2, 11.8, 12.3. Here it's 15 months. And so that was an interesting finding. And we did what the statisticians say we're not supposed to do. We compared all the trials on the same slide. And the response rate for this new drug looks a little better. The median survival looks maybe a lot better, although the data is early. And we're comparing between trials, so you didn't randomize patients between the therapies in this case. And toxicities were no worse. So this is coming. It'll add something, I think, to our armamentarium for use of targeted agents in Canada. It's been FDA approved. Health Canada's, actually in defense of Health Canada, the company went to the FDA first, and oh yeah, Canada is kind of a small country, we'll get around to it. So this is not Health Canada's fault that the FDA approved it before we did. Moving on to immune therapy. There are lots of receptors on T cells, which are one of the principal immune cells in the body, and the receptors are all there to tell them when to turn on, and especially to tell them when to turn off. because autoimmunity is a problem. We've known for centuries that if you get a big immune response to an infection, sometimes it gets too big and the patient has problems from the response to the disease, not the disease itself. Plus autoimmune diseases, where we don't know what turned on the immune system, but something turned it on to the wrong target, have been a problem for a long time. And so these, especially the inhibitory receptors, are what the body has developed to turn off the immune system when it needs to be turned off. So cancer cells, of course, being sneaky, have figured out how to use these receptors to turn off the immune system from immune surveillance of cancer. But that gives us some targets. Two in particular of these many receptors, the CTLA4 receptor and the PD-1 receptor, both of which inhibit the function of T cells at different places in the development of an immune response, both of which can be blocked by antibodies. And when you block it by antibody, it can't get turned on, and therefore it cannot put the brakes on the immune system. And so the cancer cells are no longer hidden from the immune system, and at least in a percentage of patients, a growing percentage of patients, Sonia needs to increase those numbers she was giving you a bit, have a response. So this is the first drug, ipilimumab, also known as Yervoy. How they picked that name, I'm not sure. Doesn't work in everybody. As you can see, the first part of this curve looks depressingly like the curves I showed you before. But it's a little bit shifted because the median is almost a year instead of 6 months. And what's really exciting is this is a 10-year study. You don't have a lot of 10-year studies in cancer, but ipilimumab has been around long enough that we have 10-year data, and the survival curve is flat, which means if you're in remission after 3 or 4 years, you're most likely going to stay in remission forever. So this drug is curing maybe 20% of patients. And I show you 2 slides here. One is from the research trials, and the other includes the expanded access program where they gave it to everybody with advanced melanoma. There were no picky criteria about who you could give it to. So this is a real-world result for this drug. Now, 20%'s not great, so we tried to get better. So this was the key study called Keynote 6 that compared the first. Actually, it wasn't the first PD-1 inhibitor. It was the first PD-1 inhibitor that got developed well in melanoma. Sorry if BMS is out there. They screwed this up. This was the Merck drug, even though BMS started ahead. They compared it to different, slightly different schedules with ipilimumab standard schedule. And these are the results. The blue here is pembrolizumab, the PD-1 inhibitor. You can see overall survival clearly better, and it's persistently better. The curves do not appear to be approaching each other. Progression-free survival, not quite as good, because some patients progress and still live for a while, and we can even rescue some patients by switching from one drug to the other. Still a very clear difference in favor of pembrolizumab. How long are these responses going to last? Are we actually curing patients? We don't have 10-year data. If you look at the 3 to 4 year data, it's still going down slowly. So I think the jury's still out on the really long-term complete response cure rate, if you will. Treatment-naive patients do better than all patients, so it's important to give immunotherapy up front. Chemotherapy in melanoma almost has no role anymore and really should never be even discussed. And data like this also is suggesting that when you have to choose between immune therapy and targeted therapy, it might be, in most cases, better to look at immunotherapy first, although that's controversial. There are exceptions, and I don't have time to get into all the details. But this curve for treatment-naive patients does look like it's getting flat, and it looks like it's getting flat at almost a 50% long-term survival. So that's better than IPI by more than 2-fold, maybe. Need to get further out on the curve. And we're still trying to do better than that. So, oncologists have kind of linear, simple thinking. If one drug works, that's nice. If another drug works, that's nice. If they're different, and have slightly different mechanism, then we just combine them and see if they work better. And so this study was designed to do that, and this is nivolumab, which is the other PD-1 inhibitor that's widely out there, plus ipilimumab versus nivolumab alone versus ipi alone. And so here's the data. Ipi-nivo is in orange, and you see this is progression-free survival. It's above nivo alone, way above ipi alone, just like I showed you for pembrolizumab. But the curves are not that far apart, and it looks like with time, and we don't have a lot of follow-up yet here, they're coming together. The response rate, again, is better for the combo, but not that much better. And the so-called waterfall plot, you can see, looks better for the combo, but doesn't look like the waterfall plot I showed you for targeted therapy. So we look at subgroups to find, is there a group of patients who really needs the combo? And yeah, not really. Maybe, interestingly, BRAF mutant patients respond better to the combo than they do to single agent immune therapy, which means if you're trying to decide first-line therapy for BRAF mutated advanced melanoma, you really probably want to decide between targeted therapy, which is a combination, and this immune therapy combination, which is of course not entirely approved in Quebec, although it's getting there. It's almost entirely approved in Quebec. So this is just another way of showing what I told you. BRAF wild type, orange and blue are combo versus single agent PD-1 inhibitor. Not much difference there. Here, orange looks like it's maintaining a difference over the blue. So maybe, it makes your life a little more difficult. It would have been simple if it was much better in the patients who you don't have targeted therapy to give because they don't have the BRAF mutation, but in fact, it's better, it seems, in the patients who do have the BRAF mutation. So, that leads to a lot of discussions among oncologists and a lot of company-sponsored meetings.
Yes.
The other thing I don't have time to talk about a lot, and it's even more controversial, is the role of PD-L1, which is the ligand, the protein that binds PD-1, and that's how you induce immune suppression. That's how you turn off the T cells, by having the ligand bind the receptor. You might think, naively, that if you're targeting PD-1, but there is no PD-L1, there is no ligand for the receptor, then it won't get bound to its ligand. It won't therefore be activated to block the immune system, and you don't need to treat it with an antibody if it's not going to be active. So, in theory, if you don't have PD-L1 expression, you shouldn't need, and it shouldn't work, a PD-1 antibody. In practice, PD-L1 expression is hard to measure. It's variable. It's a mess, the whole testing thing. So that simple idea isn't quite true, but it looks like it's a little bit true. So here, in patients who have PD-L1 expression that is relatively high, no difference between ipi-nivo and nivo alone. In fact, it looks like the nivo alone curve was a little bit better for a while. In contrast, if PD-L1 is really low, the orange curve here is quite clearly higher than the blue curve. So we don't yet have this available in Quebec. Even though it's a cheap test, costs maybe $100, they won't do it. Even though the drugs cost maybe $100,000 a year, but they still don't think they can afford the $100 test.
Wilson, a question.
Mm-hmm.
With lung cancer, because
Yeah.
PD-L1 is a very specific indicator for success with
In
lung
fact, it's very similar data in lung cancer,
Is that right?
except immune therapy just doesn't work quite as well in lung cancer as in melanoma. So, here, yeah, maybe a 49% survival rate is lower than a 67% survival rate, but 49% for melanoma is still very good. So you're going to give a treatment to everybody. In lung cancer, if you just move these curves down, then the response and the survival to immune therapy in patients who have a low PD-L1 expression is really probably not worth the $100,000 a year. That's why they've approved the test there and not in melanoma. Now, everything changes every few months in immune therapy. The latest stuff in lung cancer is if you combine chemotherapy with PD-1 targeted therapy, it just works great in everybody. So the movement now may be finally going away from PD-L1 testing and just give them all chemo plus pembrolizumab. But chemo has toxicity, so there's still a group that says, well, if the PD-L1 high doesn't need the chemo, do you really want to give them that? And ongoing debates in lung cancer, which is not the topic for tonight. Why don't you give everybody Ipi-Nivo if it's always a little bit better or at least as good, and sometimes it's maybe a lot better? Well, here's why. Huge percentage, grade 3-4 means bad. So adverse events with Ipi-Nivo, grade 3-4, more than half the patients. Nivo alone, a sixth the patients. Ipi's a bit more toxic than Nivo alone, that we knew. Treatment-related adverse events leading to discontinuation. Patients who have metastatic melanoma who know the immune therapy is their only chance do not like to stop taking the immune therapy. So this means they had bad side effects. And here it's 30% versus 5%. So Ipi-Nivo is way more toxic. So where does that lead? Which approved targeted therapy should we give? I talked a little about that, but more data is needed. And as I said, the third alternative combination has to come to Canada. Which immunotherapy is best? I haven't talked about the difference between nivolumab and pembrolizumab. Most simply, and probably actually precisely true, there is no difference except how often you have to give them. So whichever you can get is probably fine. There are what's called PD-L1 inhibitors, which target the same pathway on the other side of the receptor-ligand interaction. They're also probably all the same, but they haven't been as big in melanoma as in some other diseases. If one immunotherapy fails, can another still work? I think I have a slide on that if I have time. In BRAF mutated patients, which do you give? How do you sequence them? Which first? I've talked a little bit about that, but we really don't know well enough. And then the cost of these drugs. Drug companies have been raising the cost of new cancer drugs every year for more than a decade. It's really gotten out of control. I don't see anybody here I know from a drug company. No. But it's just really out of control. Somebody has to do something, and it's not going to be Donald Trump. Comparison between treatments. I talked about this. I don't want to go over it in any detail. Ipi was the first one, and it has a great effect on overall survival in a relatively small percentage of patients. Nivolumab or pembrolizumab have a great effect in a higher percentage of patients, but we don't know the 10-year curves yet. Ipi-Nivo has a rapid, I didn't show you how fast it works, but it works fast, has a response rate that is higher than anything, so 60% of patients respond to Ipi-Nivo. It surely has a survival benefit that is important, although there also the data is early. And in bold letters, it's toxic. Targeted therapy works even faster than Ipi-Nivo, works in almost everybody, has a significant effect on survival, but it's a temporary effect on survival. It's a year or two more, maybe 3, and then resistance happens in most patients. There are novel combinations, some of which are in trials at our place, and some of which are in trials in other major centers around Montreal. A lot are in trials at PMH, and I'm not going to go over all the details, but combining new therapies, and especially combining targeted therapies with immune therapies, are being tried everywhere. So, same slide as before with some answers. Right now we have 2 combinations available for BRAF mutated patients. Most people choose dabrafenib combination because its major side effect, which is fever, usually goes away, and vemurafenib's major side effect, which is extreme sensitivity to sunlight, does not go away. Most people start at least with dabrafenib. Which immunotherapy is best? I still got no answer for that. How long do you give PD-1 targeted therapy? That's a very important question that, is not just important for patients because you want to give it long enough to get the maximum effect against the cancer. You don't want to give it so long that toxicities pop up that can be serious. Obviously, it's important to the government because the less you have to pay for, the better it is. Right now, it looks like 2 years is about the limit if you don't have progression before then and if you don't have serious side effects. But the data for that is not really convincing yet. If you do really, really well, if you have a complete response, then maybe you can get away with just 6 months. And there also the data is evolving. If one immunotherapy fails, can another work? So this is important. There is good preliminary data, although it is preliminary, that ipilimumab works as often as it ever works, which means 20-some%, after PD-1 failure. Right now, Quebec allows this and funds it, and no other province in Canada does. So Quebec did one thing right, or at least hasn't gotten around to doing the thing wrong. I haven't brought it up with any regulators here. What's not funded anywhere in Canada, but is true, is if you get your 2 years of PD-1 targeted therapy and you do great, and then unfortunately you're one of those unlucky patients who do have the cancer come back a year after that, for example, will PD-1 therapy work again? And the answer is pretty often yes. And there's pretty good data for that, it's clear, but it's not clear enough for any of the provinces to pay for yet. So that may need some help from our advocacy groups. BRAF mutated patients, which to choose, I talked about that, and what is the practical answer is local funding rules may tell you what you have to do. In, again, the rest of Canada, you have to give BRAF first, just because that's the way they wrote their rules, even though it may be wrong. In Quebec, again, we have a little bit of flexibility there, so that's good. Once again, how do you pay for these drugs? Right now, we have lots of clinical trials that give the best and the newest drugs free, so I strongly urge everybody to get on clinical trials if you can. I strongly urge the hospital administrators of places that don't have a lot of clinical trials to make it easier for their patients to be referred to a place that does have a clinical trial. If you don't care about the fact that clinical trials help patients and are better for patients, care about your budget and send them off. And there are access programs that also are very good, and they take a certain amount of effort to get, and they are also only available at some centers, so you have to make sure people know where they can get drugs if there's a limited number of centers that have access. Serious negotiations, novel pricing mechanisms, difficult discussions are needed, and I would like to say the era of my having to discuss whether they should mortgage the house to pay for the therapy is over, but it's not quite over. So in summary, we've had great advances. Great advances, of course, lead to expectations, and we can't really meet everybody's expectation yet. We don't cure everybody by far. So we have to manage expectations. At the same time, we ourselves expect it to continue to get better every year. We have dramatic results, but resistance and toxicities remain problems. As I mentioned, clinical trials are proliferating and they're good, so go on them. Encourage people to go on them. Canada's a great place for clinical trials. But eventually we need to pay for the drugs, which are, in case you haven't gotten that point, overpriced. And I think that is it.